Hello, everybody. I'm Joanna Dangle. I'm the professor of pediatric cardiology and I build fetal cardiology in Poland. So I am very happy that I can share with you my knowledge as a cardiologist, as without obstetrician, this part of pediatric cardiology will not develop ever. I started fetal cardiology in January 1995, and as you can see at the beginning, we had a very little number of fetuses with congenital heart defects. At the moment, we have more than 400 new heart defects detected every year. We have very many modes in which we can see those defects. And every year we see more than 2,500 abnormal fetal cardiac scans, which is quite a lot. So what is the difference between obstetric screening and our fetal echocardiography? So in this mode, you can see the whole pictures you need to see in the obstetric view, which means four-chamber, outflow tracts, and mediastinal. In contrary, in our situation, in fetal echocardiography, we need to use all different cardiac views with short axis and the sagittal views, all other important, as well as evaluation of the hemodynamics. So, of course, fetal cardiology is a teamwork, so we need to be friends with obstetricians, and obstetricians need to be friends with fetal cardiologists. Of course, the first trimester ultrasound at the moment is very widely used worldwide. Remember that if you have nuchal translucency more than 25 centile and normal genetic tests, invasive or non-invasive, remember to do fetal echocardiography. Just recently we had two fetuses who had abnormal NT and normal scan in 20 weeks of gestation. They appeared in 30 weeks of gestation with severe impaired left ventricular function due to aortic stenosis. What is our job? Their job is to make final diagnosis and eventually to add the additional tests like genetics or magnetic resonance. We have to plan the place and time for delivery, and we should predict the neonatal condition. So we need to cooperate with neonatologists from the neonatal unit as well as with a pediatric cardiology and cardiac surgery team. The cardiovascular profile score is a very important part of our work, as we can see the fetal condition. And this is a bridge between you and us, because we can together know what is the fetal condition and what we can do basing on the Doppler findings and ultrasound findings. So if we know that in cardiovascular profile score we have abnormal venous flow but normal arterial, we most probably have the fetal heart failure, so really fetus needs treatment. However, in contrary, if we have the abnormal arterial flow and the various venous flow, but the first is abnormal arterial, most probably is the placental insufficiency. The fetus is small for gestational age, and delivery is usually mandatory quite soon. So detection of fetal cardiovascular anomalies is possible since the first trimester at the moment. However, it is not possible to make the final diagnosis, but as I saw, the big nuchal translucency and normal test is mandatory to do the fetal echocardiography even as early as in 12 weeks of gestation. What is the prenatal detection rate of congenital heart defects in Poland? The recent data we had from 2017, and you can see about 70% of hypoplastic left hearts or other single ventricles, not 100%, never it's 100%, but if we go for transposition, which is quite common defect in the neonates and life-threatening defects, it's just half of them. So still we have something to do. In Poland, we have really many operations, as I showed in the second slide. Determination rate for isolated heart defect is really very low. So in this 2017, it was more than 500 operations in more than 400 neonates, and 1/4 of them were single ventricle needed stage treatment. So some examples which can help you how to look at the fetal heart. These are defects which are quite difficult to detect. Why? Because they are called as the four-chamber view is close to normal. This is atrioventricular septal defect with common AV valve and tetralogy of Fallot, in which the fetal, in which the cardiac axis is certainly enlarged. Of course, we must know that it's not just the defect inside the heart, but we must know in atrioventricular septal defect, if there is the valve insufficiency, if there is the connection between ventricles and atrials. We have to look at the mediastinum and at the abdomen because it can be the part of heterotaxy syndrome. If you have the conotruncal defect, we always have the large cardiac axis. We have always subaortic VSD, which is not visible in typical four-chamber view, so you have to sweep transducer arterially and always you have the abnormal mediastinum. Like here, if we stop the picture, this four-chamber view and this four-chamber view in diastole, how we should measure the size of the heart, looks pretty normal. However, the axis is bigger, and of course we can see that it's not completely normal. We have quite a long left ventricular outflow, and we have completely abnormal mediastinum in tetralogy of Fallot. If we anteriorly, we can clearly see the subaortic defect. So is it helpful to see it in 4D view? I think that yes, because you can see the beautiful, the common valve and beautiful, the subaortic VSD. So of course, now we switched into the mediastinum view in atrioventricular septal defect. So this is the AV valve. Then we see the narrow aorta. So we should suspect that the neonate can have the coarct. And we can have the AVSD with small pulmonary arteries, so AVSD with tetralogy of Fallot, which is quite important too. Now we switch to mediastinum in the tetralogy of Fallot, and in each three situation, our thinking about the neonatal condition will be different. In normal tetralogy of Fallot with normal, however narrow pulmonary artery and normal flow, the baby most probably can go home and be operated on as an infant. In pulmonary atresia like this and tiny pulmonary arteries, this is the doctor-dependent defect, and the baby will need the treatment, be T shunt or some other enlargement of the pulmonary blood flow. And in absent pulmonary valve, most probably we will think that the baby will be in the very severe respiratory failure. So completely different situation. So we need really a very close cooperation. Transposition of the great arteries is quite difficult to detect in the four-chamber view. Very typical sign is the bidirectional flow across the foramen valley. We can see equal size both aorta in the front and pulmonary artery in the back. However, it is not that we detect this in the middle of gestation and that's it. By the end of pregnancy, since 36, 37 weeks, we have to look at the connection at the level of the foramen valley, because this fetus as a newborn will have severe problem as the foramen valley is almost closed. So this is the baby who will need the very emergency Rushkin procedure, so the whole team has to be prepared. Then we switched to the fetuses with abnormal four-chamber view. Of course, the diagnosis is easier, however, not always very easy. Tricuspid atresia, the first defect, thanks to which the Fontana operation was established. This is the atretic tricuspid valve, tiny right ventricle and normal left ventricle. What is important for obstetrician in such situation, it is very common that you will have the reverse A wave in the ductus venosus, which is not a sign of fetal hypoxia, but this is the sign of the high pressure in the right atrium. And the other quite common and quite easily detected by you, hypoplastic left heart syndrome without really inflow into the left heart, with nice pulmonary blood flow into the left atrium and just very wide open of the foramen ovale, which is very important in this defect. What we have to think when we have both those defects? In tricuspid atresia, the very important thing is left ventricular function, water ventricular arterial connection, because they can be normal or transposed, and size of the great arteries, because depending on this, it will be thinking what our baby will need. Will it be prostatine or not? And what the first operation will be. In the hypoplastic left heart syndrome, right ventricular function is quite important, but the most important thing is the character of flow in pulmonary base and the flow across the foramen ovale, because restrictive foramen ovale is make this fetus to be a very high risk neonate. Of course, the size of the aorta and the mitral and aortic valve patency is important as well. We must remember that fetal cardiology is not a picture. The very precise diagnosis is mandatory. Like in this picture, the fetus, the lady was scheduled because of the hypoplastic left heart syndrome. However, as we can see, this is not the typical hypoplastic left heart. As we can see, both aorta and pulmonary artery, aorta good size, pulmonary artery with forward flow quite well, so it's a bit narrow. So in fact, the better situation than in the typical hypoplastic left heart syndrome. However, this baby had a severe, had a severe restriction, actually closed foramen ovale. So in contrary to this fetus who had the completely normal pulmonary blood flow, this fetus had the biphasic pulmonary blood flow. So without prenatal intervention, this baby will die in utero or just after birth. We must remember as well that the majority of fetuses with congenital heart defect can be delivered at term. They can be delivered vaginally in a prepared institution. And more than 90% at the moment of the congenital heart defect can be successfully treated, and those people can alive until adulthood. So prenatal diagnosis help to improve outcome, like in transposition. And since at the moment, almost 20 years, the prenatal treatment of congenital heart defects is possible. However, we need to, our aim is to improve the fetal and then neonatal condition, to deliver those babies in term, and we try to change the prenatal history. So those defects which can be the subject of prenatal interventions are the biggest group is critical aortic stenosis, and the smaller group is the pulmonary atresia with intact ventricular septum. So what will happen with both those defects? If we have severe aortic stenosis, it can develop fetal heart failure with hydrops or hypoplastic left heart syndrome. The same with pulmonary atresia intact septum. Both of those defects can evolve into the hypoplastic left or right ventricle and ended with Fontan circulation. And without treatment, those fetuses with heart failure and with hydrops has a very, very high risk of death. Is that possible to prenatal changing the heart defects? Of course, it wouldn't be possible if somebody will not develop the cardiac catheterization. So the first person who did the pediatric cardiac catheterization and intervention was Dr. Victor Rubio Alvarez from Mexico, and he dilated the pulmonary valve. Then Helen Taussig, very well known, and William Rashkind, and known for everybody, Rashkind procedure, and then Charles Dotter, who put first the stent. So thanks to those people, we could say that we couldn't do something, but at the moment we can do something, like Albert Einstein said. What is the history of fetal cardiac interventions? The first survivor from 1995 from Guy's Hospital. The ladies at the moment, adult person, 25, more, almost 30 years of age, fantastic. Then a real program started in Boston, 204, the first results were published, and the biggest program in Europe is in Linz, Austria. So we really do something. Just to show you how this fetal intervention work, just recent cases, the fetus in 26 weeks of gestation, the first baby of this mother died due to hypoplastic left heart syndrome 2 years earlier, a very poor left ventricular function, monophasic inflow into the mitral valve, and more than 2 meters per second outflow of the aortic valve. So this lady was scheduled for fetal valvuloplasty, and this is the puncturing of the left ventricle, the guide wire across the aortic valve, and the balloon in the aortic valve. And just 2 weeks later, you can see that the left ventricle is really working fantastically, and there is the forward flow in the entire aortic arch. In contrary, and this is the baby girl, she was born 3 weeks ago, perfect left ventricular function, of course, bicuspid abnormal aortic valve with a gradient 19 millimeter of mercury, biphasic flow across the mitral valve. The baby went home and waiting for the further procedures. Then we have the other baby, 31 weeks gestation, very similar poor left ventricular function, very similar gradient from the mitral regurg and more than 2 meters per second aorta. This baby didn't have the aortic valvuloplasty. The neonate was born. You can see very, very poor left ventricle, monophasic inflow, very low pressure in this left ventricle, very poor function, 23%. The baby had the aortic valvuloplasty, got levosimen done. The function of the left ventricle in 2 months improved, but the baby spent 2 months in the hospital, and we don't know what will be later. So it is most probably that this ventricle will work much better if the fetal valvuloplasty could be done. So compared both results, almost the same initial situation, poor left ventricular function, prenatal prenatal valvuloplasty, and the baby after birth without treatment, and after birth with treatment, with postnatal treatment. So we established our program in Warsaw in 2011. Until March this year, we performed 128 procedures, most common 95 procedures in 88 fetuses with severe heart failure, with very low procedure-related death and quite high successful rate. What is the results? As you see, we were learning how to improve the outcome of those fetuses because we really didn't know how this left ventricle will work. So as you can see, since 2016, the number of biventricular circulation is much better. However, this is a very difficult group of fetuses. And as you can see, just after fetal valvuloplasty like this is a very poor function with huge pericardial effusion, which resolves completely just after the fetal valvuloplasty. So this procedure worked, and it should be done in experienced hands and experienced institutions. So what is our own experience, how to predict the biventricular outcome? If we have the larger ascending aorta, this is more likely. If we have triangle score published in Boston a few years ago, and if the interventions was later. So we think that this ventricle had just impaired function, but its size was quite good for being the left ventricle. But the size of the left ventricle, mitral valve and aortic valve diameters will not have a big impact on the biventricular or single ventricular outcome. So in conclusion, fetal aortic balloon valvuloplasty can be is technically possible The mortality is low and low complication rate for the mother and the fetus, but it must be stressed that it must be done by the experienced team with very experienced obstetrician with different fetal procedures and very experienced interventional and fetal cardiologists who know what is the what are the criteria for fetal cardiac interventions and how to do it and how to treat those babies after birth. This is the crucial things to have the good outcome. We must know that fetal aortic valvuloplasty is not the one group of fetuses with the same defect, which we have early in pregnancy, very severe aortic stenosis with very poor with very poor left ventricular function. This is most probably evolving hypoplastic left heart syndrome. And in such situation, we think that we are able to change the prenatal history. Then we have the severe heart failure, secondary to aortic stenosis with a revived hydraps, and normal for chamber view in the May trimester, and dysplastic mitral valve syndrome, very, very, very poor outcome everywhere in the world. In our series, out of 8 fetuses with hydrops, in all hydrops results, and all were born in term without hydrops and can be treated after birth. And then the other group of fetuses, much smaller but fantastic outcome, pulmonary atresia, intact septum with monophasic inflow into the right ventricle, reverse flow in the ductus venosus. It must be patent right ventricle outflow, right heel, and left to right shunt across the arterial duct. So this is, as you can see, the picture is much worse. This is the obstetricians have to puncture the arthritic valve, and then this is the balloon in the pulmonary valve and artery. Very poor picture, unfortunately. And this is our first patient, tiny right ventricle without tricuspid recurge, completely arthritic pulmonary valve, and beautiful outflow after opening of the pulmonary valve. And this is this girl, Emilka, who is completely normal girl with completely normal right and left ventricle after additionally to the dilating the pulmonary valve after birth. She needed to have the Amplatzer into her atrial septal defect, completely normal girl. So we did 15 procedures in 13 fetuses. 11 of those children could have the biventricular circulation. This is a baby whose mother was counseled at her first fetal echocardiography exam somewhere that it will be the single ventricle, so she can consider the termination of pregnancy. But because she didn't like to do this, she came to our unit. And this is the heart of this girl of the 2 years of age, completely normal heart, not needed anymore situation. So in pulmonary atresia, intact septum, results are really fantastic. The right ventricle is very plastic and can really grow if we open the outflow tract and if we open the pulmonary valve and let the blood come through the tricuspid valve and outflow from the pulmonary artery. So in conclusion, we must know that fetal cardiology must be a teamwork to avoid mistakes and obtain the best results for treatment of babies with very complicated congenital heart defects, which are evolving in pregnancy, and we have to think how we can improve the fetal and neonatal condition in any possible situation. Of course, if we are thinking about fetal cardiac intervention, they are shines and shadows, but as a chance, they are technically successful. And during the last 5 years, we didn't lose any baby, any fetus after the intervention. It is recommended to be trained in the centers with experience to avoid technical complications. We started this, and thanks to Gerard Towson and Wolfgang Arts, we visited their center and saw how they are performing this, so we avoid the very difficult learning curve. The aim of the fetal intervention is not to treat the entire defect. It's give to baby the better chance for successful treatment after birth, because majority of them will need those treatment. And the shadow is that the long-term results will be known in the future. So we need the international cooperation, and we are the part of the International Fetal Cardiac Interventions Registry and the APC, in which we are planning the prospective study. So thank you very much of your attention. And I think that the fetal cardiology is the worldwide field of pediatric cardiology and obstetrics. And I think that this fantastic quotation of Rudyard Kipling that if you can, you should trust yourself when all men doubt you, but you must make allowance for that doubting too. So the questions and answers and all doubts and discussions are absolutely mandatory to have the best results and best cooperation. Thank you.